also Professor Neil will be sharing to us about on the cardiac effects on therapeutics, and it will be led by the moderators of Dr. Sally. So in line with our company mission, which is building a healthier Indonesia, one person at a time, and a part of our commitment to support the improvement of the quality of doctors and healthcare workers in Indonesia, we strongly support this meeting in the hope that we can exchange ideas that we can apply daily in solving the above said cases. Last but not least, I would like also to express my appreciation to the honorable speakers, moderators, and all doctors attending in this virtual symposium, and also the organizer who have spent time and lots of energy to make this symposium run successfully. On behalf of Daria Varia Management, I truly apologize for the lack in organizing of the event, either in delivering the event, administration service, and the limitation of the facilities. I wish the symposium could give great benefit to all of us, particularly to the honorable professor and doctors and participants of this webinar. Stay safe and have a nice symposium. Thank you.
Terima kasih Bapak Dedi Septiadi atas sambutannya. Kali ini kami mengundang Dr. I Gede Putra Suteja selaku Ketua IDI Wilayah Bali untuk menyampaikan kata sambutan.
Atau mau itu pakai aqua dong? Ayam. Ini kan ngotot itu, ya serat.
Pada Dr. IGD, kepada Dr. IGD Putra Suteja dimohon untuk menyalakan mute mic-nya untuk menyampaikan kata sambutan.
Kok bisa lagi ngomong?
Halo dokter. Tunggu sebentar, kepada Bapak, Ibu, Profesor, Dokter sekalian, ada sedikit kendala teknis, kami sedang menunggu kabar dari Dr. IGD Putra Suteja. Sebenarnya sudah online tetapi masih belum terdengar suaranya. Halo dokter. Baik, mungkin ada sedikit permasalahan teknis. Kalau begitu kita langsung saja lanjut ke bagian acara berikutnya. Memasuki Scientific Session 1, kami mengundang Dr. Sally Anantaria Atmadikusumah yang saat ini menjabat sebagai Head Division of Nuclear Cardiology and Cardiovascular Imaging, Department of Cardiology and Vascular Medicine, Faculty of Medicine, University of Indonesia, National Cardiovascular Center Harapan Kita. Dr. Sally menyelesaikan pendidikan di Fakultas Kedokteran Universitas Indonesia Jakarta pada tahun 1999 dan menjadi kardiologis di Fakultas Kedokteran Universitas Indonesia Jakarta pada tahun 2013 dan juga mendapatkan gelar Master of Medical Education Fakultas Kedokteran Universitas Indonesia Jakarta pada tahun 2017. Dan Dr. Sally juga aktif di organisasi-organisasi seperti Indonesian Medical Association, Working Group of Indonesian Society of Cardiovascular Imaging or ISCI Indonesian Heart Association, Indonesian Society of Hypertension or INA-SH, European Association of Cardiovascular Imaging or EACVI, dan juga Asian Society of Cardiovascular Imaging or ASCI, dan juga Society of Cardiovascular Magnetic Resonance atau SCMR. Dan kepada Dr. Sally, waktu dan tempat kami persilahkan.
Hello. Hello. Hello.
Yes, Prof. Sally, you're online.
Okay, good afternoon, everybody. Welcome all dear seniors and my colleagues. And thank you for finding time and joining today's virtual symposium. Thank you, DVL, for having me in this beautiful weekend. And I'm very pleased to be today moderator in today's exciting symposium, of course. This is great. And in our power and tolerability virtual symposium, we will start with our topic. And the first speaker will be Associate Professor Neil David Cohen, MBBS FRCP. And how are you doing today, Prof? Nice meeting you again. And I hope you're keeping safe during this challenging time. Let me introduce to all of the participants that Professor Cohen is a clinical researcher and head of the Diabetes Clinical Research Laboratory at the Baker Heart and Diabetes Institute. And currently he's Director of Clinical Diabetes, Consultant Physician and Head of Pathology at the Baker, as well as holding an adjunct clinical associate professor position with the School of Public Health and Preventive Medicine, Monash University, and associate professor, School of Pharmacy, University of Queensland. And he also holds the lead role for governance, development, and management of diabetes specialist services at the Baker since 2007, including obesity, respiratory, and ophthalmology services, Victorian telehealth service, and satellite service in Melbourne. So I believe you can also look at the CV in the screen. So without further ado, I'm gonna have an honor to have Professor Cohen have the time now. Time's yours.
Thank you very much. Okay, thanks very much for that kind introduction, and thank you for having me this afternoon. I hope you can all hear me well. I'm going to discuss today the cardiac effects of diabetes therapeutics, particularly relating to type 2 diabetes. We're in a new era of diabetes management, and hopefully I'll explain why as this talk goes along, but we now really have a very strong understanding of the effects of glucose lowering and therapeutics on cardiovascular outcomes. So I'm going to concentrate on three key issues. One is diabetes as a cardiovascular risk factor. One is blood glucose or glycemia and cardiovascular prevention, and hypoglycemic therapy or hypoglycemic agents in cardiovascular safety and prevention. So we all know the effects of diabetes on cardiovascular disease, and at least 50–60% of our patients die of cardiovascular disease. We know about the renal and peripheral effects and retinal effects as well. So this is not news to any of us, but we also are very much aware that diabetes is a cardiovascular risk factor. And here we can see that this is vascular outcomes with diabetes, that the effects of diabetes on coronary disease and coronary deaths are effectively doubled. and this is something that we're very well aware of. We're also aware in males and females here that there are many life years lost in association with diabetes. And if you can look at this graph, and in particular look at the very high risk groups here, and you can see that a patient aged around about 60 who has stroke and MI, or indeed diabetes, stroke, MI, loses 15 years. But if you just have diabetes and myocardial infarction, or diabetes and stroke, you still have considerable life years lost, and the same is there for males and females. Again, this just looks at mortality and diabetes, and you can look at mortality rates or hazard ratios here, but you can certainly see that having diabetes is a major risk factor here, with diabetes and stroke, diabetes and MI, essentially having the equivalent effect of having stroke and MI, for example, at 4 times the mortality rates. So I think we know that there's this relationship between diabetes and mortality, and despite mortality rates coming down, as we can see, there is this gap between people with and without diabetes that really is not narrowing, and I guess that is also of significant concern. This is data from the Swedish National Diabetes Register. So really, where did it begin? And in terms of intensive glucose lowering, we did ask the question, how much does lowering glucose reduce the risk of complications of diabetes? It seems an obvious question, but the UK PDS was the first study to address this many years ago now, and it asked this question, and it also asked the question about safety as well. And of course, in that era, type 2 diabetes was treated with metformin, sulfonylurea, or insulin. So the UK PDS study was a simple design where patients were randomized to intensive glucose lowering or conventional therapy, and there was an arm of metformin in obese or overweight patients of only 340 participants as well. So they managed to separate the 2 arms of the trial. Conventional had a mean hemoglobin A1C of 7.9% and intensive 7%. You can see initially, this is patients from diagnosis of diabetes, had a drop in HbA1c, and over time, despite intensive therapy, there was still a worsening of diabetes control, but this was parallel in the conventional group. So we have this nice separation of glucose, and the question is, what effect did this have over a 10-year period on outcomes? And here is the answer, and we know that the microvascular outcomes in particular were strongly reduced, but really this is where the controversy began. So in myocardial infarction, we have a 16% reduction, but famously a p-value 0.052. So there was much argument about the significance of that outcome. Interestingly, when you look at the 3 arms of the trial, and in particular conventional here in white and intensive therapy in yellow, there was this separation which was not quite significant. But if you look particularly at this metformin arm, even though there's only 340 patients, there was a significant difference between the metformin and conventional therapy. And from this small study, this small sample, we have almost folklore now, I suppose, that metformin is cardioprotective. Having said that, I think it's important to recognise the small numbers in this study and the fact that this was not a blinded trial. Interestingly, if you, at the end of this trial, take your p-value of 0.052 and your 16% reduction in MI, and you follow these patients for another 10 years, you actually see a legacy effect, and you do have a significant reduction outside the study of myocardial infarction 10 years later, and this is also reflected with the microvascular results. So we believe that there is some sort of legacy effect of having low glucose in the long term. So there were other studies, and this is the advanced trial looking at intensive glucose lowering based on a sulfonylurea. But what this showed was microvascular benefit, but no significant macrovascular benefit. And this was a larger study, and the aim was to achieve an HbA1c of less than 6.5%. so more intensive than the UK PDS and bigger study. This is the Accord trial, and this trial in particular looked at the effect if you try and titrate HbA1c down to less than 6%, so quite an aggressive study. And although you can see the intensive group did better in the primary outcome, although not significantly so, this was an interesting signal where we had an increase in death, mortality from intensive therapy. And this was a surprise, and because of this result, and it was borderline significance, the study was stopped prematurely. And so that was really something that we haven't yet been able to fully explain, and maybe a chance finding. And so if you put all these trials together, looking at the effect of glucose lowering in type 2 diabetes on major cardiovascular events, you can see that all to the left of unity. And although none of them individually reached statistical significance, we can see that the overall effect is a reduction of about 9%, given an HbA1c reduction that was modest at about 0.8%. So I think there is a signal from these trials, from a meta-analysis, that glucose lowering is beneficial for cardiovascular events, but the effect is small. Now, one of the other questions that is often asked is there a glycemic threshold? And I think what this analysis shows quite nicely is there is an inflection point if you look at major macrovascular events, microvascular events, all-cause death. And certainly for the major macrovascular events, there seems to be a point at 7% where you get an increased risk, whereas microvascular is 6.5 and all-cause death is 7%. So I think there is a hint from this analysis that there is a threshold, let's say, of 7% for cardiovascular. He's 8-10 years in the Veteran Affairs VADT, a bit longer, and they showed lesser results. And there's been a lot of talk about why that might be the case. And one of the thoughts is along these lines, that which
harusnya bisa kan? Itu kayaknya kok harus register gitu ya?
Kayaknya langsung ini coba zoom saya.
Ini kan udah masuk masalahnya, sudah masuk akun jenengan.
Ya langsung ini baru ini.
Coba kita pakai yang ID-nya dulu ya.
Lah pakai ID, pasti ID harus orfas. Nih, uangnya enggak mah.
Ya kalau emang dikenali bukan nama orangnya.
Apa?
Bukan dikenali sama orangnya.
Niki. Kenal niki. Aku kok ndak mlebu sik, terus aku dipanggil.
Oke.
Gue kira mlebu kono. Orfas sing semuanya.
peran
Iya, Madiun Cimilin.
Madiun.
Iya.
Kasusnya lupa.
Lupa.
Saya tak carinya barangkali ada.
Aku selalu pas sudah ketemu ganggu. Kenapa gak langsung? Kok lain?
Pakai gitu ya, tadi pakai akun saya masalah. Madiun. Kon Google.
Ini peran Madiun Cimilin. Peran 4695 Pentung.
Coba ya.
Peran 4695 Pentung.
Peran.
Ya, tunggu tuh.
4
Halo.
95.
Halo, iya. Saya bentar lagi, saya tak cobanya lagi. Sebentar, ya. Di promote, aku rasa harus di promote.
Yo, resen aja berarti ya.
Ya, rasa harus di promote, resen dulu. Sekarang tak resen sekarang tak resen dulu. Ya, sekarang resen coba dilihat. Resen. Ya. Resen dulu atau masuk dulu aja menurut saya. Terus resen. Untuk siapa?
See this as a small number of events and certainly not adequate to have any great certainty about activose. So the question needed to be asked, is activose in fact cardioprotective? And so the ACE trial was performed, and this was a larger study, cardiovascular outcomes trial. Any benefit? It is neutral, so there's no adverse cardiovascular effect of activose, but there's no benefit either. So then we come into the era of DPP-4 inhibitors, and we can see that these are very widely used oral agents, as you'll be aware, and we really wanted to know of the safety of these agents in diabetes, and so these cardiovascular outcomes trials were performed, and you can see here saxagliptin, alogliptin, sitagliptin, all these major trials were done, and the trials are designed for glucose equivalence. So we're really just looking at the effect of the drug, not the effect of glucose in these trials, but you can see they're neutral. So they're safe drugs. There was no adverse signal at all, but there's no benefit either. So these drugs are glucose lowering agents. They don't have any specific effects on the cardiovascular system. Now, this is a bit more interesting because this is linagliptin versus a sulfonylurea. So the sulfonylureas have been a question mark. There was some data suggesting adverse cardiovascular outcomes with some of the sulfonylureas and direct cardiac binding, but this was really unproven. So I think the Carolina trial, which was recently performed, really compared linagliptin to glimepiride, and we know linagliptin is neutral in terms of its outcomes compared with placebo. So this was a pretty good way to test whether sulfonylureas were adverse from a cardiovascular point of view. And you can see here, 3-point MACE graph, they superimpose. There's no signal at all of adverse events of the sulfonylurea glimepiride. And that is despite quite a marked difference in hypoglycemia rates you can see here. So we know that glimepiride is associated with more hypoglycemia than linagliptin, but there's no adverse cardiovascular events. And really, to some degree, this puts to bed the talk about an association of severe hypoglycemia and cardiovascular outcomes. We know there's an association, but we don't really know if there's cause and effect. This trial would suggest that the association is just that, an association, and there's not a cause and effect between hypoglycemia and adverse cardiovascular outcomes. So then we come to this amazing new era. So we have SGLT2 inhibitors, sodium glucose transport inhibitors, and these are agents that act on the kidney. And so, as you'll be aware, all of the glucose really is filtered through the glomerulus, and if it wasn't for sodium glucose transporters, it would all come out in the urine. So we know that SGLT2 in particular reabsorbs about 80 or 90% of glucose. And really someone came up with the idea that if you have hyperglycemia and obesity, maybe losing glucose in the urine is not such a bad idea. And it turns out that, yes, these are good glucose lowering drugs, but they have a range of other effects that are truly remarkable. So the first hint we had was the EMPA-REG outcomes trial. And so this is empagliflozin, this is the outcomes trial. And it was a trial designed to look at empagliflozin at 2 different doses compared with placebo, a large outcomes trial. And these were for patients with type 2 diabetes. And you can see the HbA1c range. All these patients needed to have established cardiovascular disease. So these were high-risk patients, and they had to have renal function with an EGFR greater than 30. And so I don't think we expected anything more than the DPP-4 inhibitors studies, but this is the baseline characteristics, HbA1c around about 8%. You can see this is a group on insulin, about nearly half of patients on insulin, long-standing diabetes, BMI around 30, mostly on ACE inhibitors, antihypertensives, statins. So this is a well-treated group of patients with cardiovascular disease. And so we really didn't expect to see a huge benefit, but this was the primary MACE outcome, and the whole world was shocked and surprised. And you can see here from almost day one that we have this separation of these 2 lines with empagliflozin associated with a significant 14% reduction in cardiovascular outcomes. Now, even more impressive was cardiovascular death. So this whole result was really driven by cardiovascular death, and you can see a 38% reduction in cardiovascular death. Now, mechanism here is really not at all clear, and we were really surprised. And again, you can see how early these lines separate. And when you look at this outcome, you can see again, it's driven by cardiovascular death, not so much by non-fatal MI, non-fatal strokes sort of the other way. So it just seems to be a really powerful effect on cardiovascular death. Now, we have further explored this. So this is just looking at the outcomes of HbA1c in this trial. You can see a small HbA1c reduction. You can see small weight loss and small blood pressure lowering, and these are known effects of these agents. And it is certainly possible that some of this is driven by these small results, but certainly we would not expect to see the sort of reduction in cardiovascular death we're seeing with small drops in blood pressure or weight or HbA1c. And really that thinking is that it's unrelated to any of these issues. So other SGLT2 inhibitors, we've got canagliflozin, and this again showed a primary outcome benefit of 14%, very, very similar result to the EMPA-REG outcome study. The dapagliflozin trial, so the DECLARE trial, and this showed, in fact, their primary endpoint was cardiovascular death or hospitalisation for heart failure. And they had a slightly different cohort in this trial, which was not just patients with established cardiovascular disease, but a mixed group, some who had just high risk factors. So it was a lower risk population. But you can see a nice result for cardiovascular death or hospitalisation for heart failure. This was driven mainly by heart failure, and we now know these agents have a particular heart failure effect, and this may be driven by diuresis and sodium excretion to some degree. So again, just looking at that result, and we can see here that that's the primary outcome. The MACE outcome did not quite make significance, but you can see that death from any cause did not quite make significance. But here's the key driver here is hospitalisation for heart failure in this particular study, and some renal benefits as well, which we can talk about as well. So if you put these trials together, these key studies, again, you can see that the primary MACE outcome, although not significant in all of them, certainly stands up with a hazard ratio of 0.89 or 11% reduction in primary MACE. And so this holds up, and despite the small differences in these trials and DECLARE being a slightly different study, which was not just secondary prevention. I think we're seeing a nice class of